Good morning, everyone. Thank you for joining us for this rapid fire session. So it's based on AI, digital innovation, and virtual health. And so we have quite a number of speakers to go through this morning. So I'm Dr. Kendrick Shi from Hong Kong, and we also have Dr. Rao, currently in the US.
Yes, thank you.
And so we'll be the chairs and also some of the speakers today. So just to kick it off, we'll have our first speaker. So each speaker has 5 minutes. So the first speaker is Dr. Vishal Ambani, and the topic is feasibility and patient experience of a pilot artificial intelligence-based diabetic retinopathy screening program in Northern Ontario.
Hi, good morning, everyone. I'll be talking about our project on the feasibility and patient experience of a pilot AI-based diabetic retinopathy screening program in Northern Ontario, Canada. These are my financial disclosures. So just to give you some context, this is a map of Ontario. The orange portion is Northern Ontario and the green portion is Southern Ontario. So obviously Northern Ontario occupies a much larger geographic area, very vast geographic distances with dispersed population, and it is a low resource region with limited access to care and physician shortages. So the results that I'm presenting are from the phase 1 of our study, which was conducted in Thunder Bay, Ontario, and this was in partnership with Orbis Canada. So the purpose was to provide real-world evidence on the feasibility, implementation, and patient experience of using AI for DR screening. It was a prospective study where we took retinal pictures of patients with diabetes, and these were analyzed with AI software at a primary care appointment with the patient's regular family physician. I'm just going to skip the video in the interest of time, but this is the software that we used. It was the iArt system by iNook, which is a Health Canada approved AI system for diabetic retinopathy screening and detection. And we use the iCare DRS Plus camera. And the main reason for using this camera was because it allows non-mydriatic imaging of the retina. So this is a busy slide, but what it tells us is that once patients came into their primary care appointment, they were offered participation in the project. The images were taken with the retinal camera. If diabetic retinopathy was detected, then they were referred to see an ophthalmologist, whereas if it was absent, then they were asked to come back again in 12 months. So these are pictures of the iNook analysis of retinal images, and it detects either more than mild diabetic retinopathy or markers of diabetic macular edema. So if those are present, then it is considered as a positive screen. So we had 202 patients who were all from Thunder Bay. Interestingly, almost half of the patients had not had an eye exam with their optometrist or ophthalmologist in the past 1 year, 11% in over 3 years, and 2% actually had never had an eye exam. We were able to complete the artificial intelligence-based DR detection exam in 92% of patients without any dilating eye drops and an additional 1.5% with eye drops. The most common reason for an unsuccessful exam was small pupils where the patient refused dilating eye drops. Now we found positive imaging in 22% and negative imaging in 78%, which basically means that only about 20 out of every 100 patients needed to see an ophthalmologist, and thereby it decreased the workload in a low resource area. We also got patients to answer a questionnaire at the end to detect, to see how satisfied they were with this experience. And the scores were very high, over 4.5 by 5 for all the questions. And especially the patients found a lot of value in not having to wait for a separate visit with the ophthalmologist for eye care, and also not having to have dilating eye drops for their appointment. Now, we use the iArt system because it was Health Canada approved. There is a lot of evidence in literature telling us that it is very highly sensitive, close to 95%, with a decent specificity, and it is also flexible with the choice of camera. So in summary, these systems can be installed either in primary care offices or in communities. there is no need for an ophthalmologist image review, and therefore it is a value in areas with low resources. You get a real-time decision at the point of care with good sensitivity and specificity. It reduces the need for patient travel and has potential for cost savings for the healthcare system while ensuring high patient satisfaction. I'd like to acknowledge all these people from my team. Thank you.
Thank you, Dr. Bambani. I think it really highlights how you can use technology to really help with such a vast area. So we'll leave all the questions till the end of the session.
Sure. Thank you.
Thank you, Dr. Bambani.
The next talk is by Dr. Juping, and the topic is the application of large language models in patient education for diabetic retinopathy. Do we have the speaker here?
Liu Juping? Maybe visa issues, I'm not sure.
Sure, maybe we'll move to the next then, if
sure.
she's here. Okay. The next one is on AI-based quantification of retinal vasculature parameters in uveitis. Vein tortuosity differentiates uveitis with active tuberculosis from latent tuberculosis uveitis and toxoplasmosis uveitis by Dr. Putera.
So thank you very much for the opportunity. My name is Iwan. I'm from Indonesia and currently doing PhD at Erasmus MC. I would like to talk about retinal vascular parameters for uveitis based on AI quantification to spot on active TB. I have no conflict of interest. So talking about TB, Indonesia is the second leading country with high TB incidence, and it also reflects to the causality of TB or of uveitis we have. So among all uveitis, we spot on at 8% patients with active TB. And if we also calculated those with positive IGRA or MANTU test, this number high into half of our patients. So it's remain a burden in our country to spot on TB as a cause of uveitis. So the problem with TB uveitis is we have clinical manifestation that's suggestive of TB, but based on our data at 10 years cohort, this only appeared in 50% of our patients with active TB, meaning that if we just rely on the clinical manifestation alone, we may miss half of patients who actually probably have active disease and open TB. So in terms of ophthalmological tool that are available broadly in our country, we think of why we don't use fundus photograph. Maybe we can have better idea to spot on active disease. And at this time, we spot on with the retinal vasculature. This was inspired by the fact that in COVID-19, even though patient may be asymptomatic, we may find alteration in the retinal vessel. So it's also possible to happen in TB because granuloma is the hallmark of TB, may produce VEGF and other inflammatory markers that can affect vessels, including retina that we expected. So the use of the AI, in this case, we would like to spot on active TB because patients first can come to ophthalmologists and we may miss open TB and we get exposed. So if we can earlier detect the TB and get treatment initiation earlier, it will achieve a better outcome. So this, we made use of our stored fundus image in 1 year cohort. We have TB uveitis with active disease and those with only supported by IGRA positive. We make use of controls which is toxoplasmosis. Then we have those eyes with affected toxo and also second controls non-affected eye. So this is just a flow diagram of uveitis, but the problem with uveitis is you may have obscured view in the back of the eye. So we would like to have some drawbacks. If we exclude all those with this blur image, we may miss with severe disease. So if the AI still can quantify more than 50%, we still analyze, and we have to really look at the vessel if the annotation works still good. So we made use of this publicly available GitHub package, which developed at Erasmus MC by our team. And there are several other packages, but if you look at how this package annotate and segmented, it's appear better than the other two widely available public package. And we can quantify several parameters in terms of artery and veins. And this is just how to illustrate the package work in ocular TB and toxo. And you can see that blurred image, we have to look at the vessel if it's still goodly better annotated. So there are these parameters. I just want you to look at that vein tortuosity that appeared discriminative in all these 4 groups. And if you look at how this comparison works, it's actually good at the those without cataract, without vitritis, meaning that the vessel itself, if we can better visualize, it can better idea how to discriminate the disease. In terms of diagnostic performance, it's a bit good to moderate to good. So we think that we can go on with this package. And because there are several serial measurements, we also see that these parameters tend to be normalized. So it's made possible to also use this package in terms of monitoring if we have extended validation. So in conclusion, even though uveitis is difficult, maybe 25 or 30 diseases covered in one umbrella, it's still possible to use AI in terms of uveitis, but we have made context which specific tasks that AI may use work. It's not covered everything in this 30 disease, but if we may spot on some parameters that probably work in certain tasks that help ophthalmologists to diagnose or to monitor the disease, it may be a good choice. So still, this is open for teleophthalmology, not only for diabetics, not only for AMD, but also for uveitis. And if you go for handheld device, it's with this just fundus photographs, it's possible. If you look at the full details, because it's not covered in these 5 minutes, you can see our recently published paper in ophthalmology and therapy, or just directly scan the QR code and you get on the paper directly. Thank you very much.
Thank you so much. We'll take the questions at the end. Very relevant talk. We'll move on to the next.
Thank you. So our next speaker is Dr. Eisuke Shimizu, and the title is Utilizing Artificial Intelligence for Cataract Diagnosis from Portable Slit Lamp Video Images. Thank you, Dr. Shimizu. I think it's this.
Okay, this is now my slide. Okay, so, just turning the slide, I'm just gonna explain about what we do. So we have done making the AI to diagnose the cataract, which the ophthalmologist doesn't need, of course. However, the tools that we made it up is a screening device, so that it is great for the screening purposes. Now, as you can know that the AI in the ophthalmology is growing these days. And as I'm the clinician, I think that we want to use the tools with the AI in it, or some kind of the similar technology in it. So the modern studies are focusing on to the posterior part of the eyes, because the fundus photos, OCTs, there is a tremendous data worldwide. However, in the diagnosis of AI in the anterior segment is now start to growing. The reason is that, of course, there is more than 5 method for the elimination method in the part of the slit lamp microscopes. On the other hand, using the anterior segment OCTs or other similar tools to measure the eyes, there is several evidences with that. Now, moving on to the talk of the cataract, this is one huge study had done in China in 2019, gathering about 40,000 slit lamp photos from the 5 institutes. The sensitivity and specificity is about like this. So what we have done here about the idea, the thing that we want to create the AI is that we have to gather the huge data, similar kinds of the data. For example, for the anterior segment photo, we have to gather as many photos as possible to create more accurate model. However, I believe now we have like 20 ophthalmologists here, or maybe more, which means that we have 20 or 30 variations of slit lamp, examination methods. So this is pretty much the hurdle, how we cannot create the anterior segment AI. So what we have done is that we use this tool, the smart eye camera. This is a tool which converts the light source of the smartphone into the thin slit beam, as you can see on the left part of the slide. By the way, this is a very cute boy, my son. Okay, sorry, no one's laughing, so I don't do this anymore. But anyway, the thing is that we can get the video with the same quality, same things of the images, so that if we can record one video, we can extract as many frames as possible. Now, we start from the cataract, and that choose the WHO grading because it is the most simple grading in the cataract. So we get about 1,000 eyes from single institute, get video data from all the patients, and we extract about 140,000 frames from 835 eyes. And then because it's video, so we divided all the video into the diagnosable or non-diagnosable frames, which was done by the ophthalmologist. Of course, I'm not the only one who have done it. It's too much for me to do. But we used several ophthalmologists to validate all the video data into the diagnosable or non-diagnosable, and then annotated all the data into these NUC stages. Now, this is the result. So this is a little bit bulky, so I'm just going to explain you shortly. So there was a quite good performance of the sensitivity of about 95%, specificity, I'll say roughly about 0.9, so 90%. Frames and eye is a similar idea, but the frames is the performance of each frames, and the eyes is by the eyes. So as you can see by the eyes, the performance will be slightly getting better. And about the grading, so NUC 0 is about no cataract, 1 is mild, 2 is moderate, 3 is severe. It is pretty easy for us to speculate that 0 and 3 have a more high because it's easier for us and AI to validate. And that is what we shown at the high AUCs. As the visualization using the GradCam technique, with that we can see that the AI is observing where we want to see. And the comparison with the conventional study, which is with the Chinese study, we had the roughly similar performance, which we think that comparing the conventional slit lamp data versus this smartphone data could be similar. So it could be the possible screening tool, which we can use it from nowadays. Limitations are these: we have to validate more and having to corroborate the data, the doctors in India. Okay, so that is my talk. Thank you very much for your attention.
Thank you, Dr. Shin.
Very nice talk. Thank you. Appreciate it. So the next talk is by Dr. Kelvin Joseph, and the
Oh, okay, changed
right?
order.
Is
Yeah.
that right?
Yeah, I think so. Change, sorry.
And the topic is effectiveness of AI-based diabetic retinopathy screening in primary care and endocrinology settings in Australia, a pragmatic trial.
Yep.
Okay.
We'll introduce the next talk after.
Sure.
Good morning, everyone. My name was printed wrongly as Kelvin in the original system, but it got changed recently. I could see even the flex outside, it's all done. No problem. Yeah. So good morning, everyone. So this is a study we conducted in Melbourne, Australia, to look at the effectiveness and feasibility of artificial intelligence-based opportunistic screening for diabetic retinopathy in Australian real-world settings. I have no conflicts of interest. So diabetic retinopathy is a leading cause of preventable blindness. We all know that. And in Australia, the prevalence among people with diabetes ranges from 25 to 32%, of which approximately 4.5% are vision-threatening diabetic retinopathy, and many remain undiagnosed and at risk of vision loss because of the asymptomatic nature of the problem in early stages. And early detection is essential for preventing vision loss. And the current screening models based on retinal images has many challenges. Primarily, it requires a trained vision technician to capture the images, and then it requires expertise of an ophthalmologist or an optometrist to do the interpretation. So considering this context, the Center for Eye Research Australia came up with an AI initiative for DR screening, which is a fully automated AI system for retinal imaging and grading. It enables opportunistic DR screening in general practice and endocrinology clinics, basically non-eye care settings where you don't have a specialist. But the idea is to reduce reliance on ophthalmic technicians and eye care professionals to do the first level screening. And the intention is to address the existing gaps of low screening uptakes and the delay in interpretation of the images. So given this background, we aim to investigate the diagnostic accuracy, feasibility, and end-user experience of this system in real-world primary care and endocrinology clinics in Australia. We had 5 study sites, 2 GP clinics and 2 endocrinology clinics in the state of Victoria, and an Aboriginal medical service in Western Australia. So the AI-based system is performed while patients wait for their GP or endocrinology appointments, so that we don't add any waiting time to their to the patients. And once they place the head, the patients are guided by a voice instruction to focus on a target set inside the camera, and the fundus camera gets automatically focused and captures image of the retina. And the immediate interpretation is done by the AI software that is integrated into the camera, and a QR code is generated, and by scanning that, the patient can get a single page grading report, which includes fundus image, the DR grading, and the referral recommendation to their mobile devices. And patients are referred based on the outcome. If there is a positive outcome, they are referred to optometrist or ophthalmologist by the general physician or the endocrinologist. And the retinal images were human graded to form the ground truth. Broad results, the mean age was 62.6 and 53% were women. And we recruited 863 participants, and we could image 76% of the patients successfully, and so about 13% were ungradable images due to whatever reasons, and 36% of the patients were referred for detailed eye examination, and we followed them up after 3 months, and we could reach only 77%. And of that, more than 47% had complied to the referral. And we looked at the diagnostic accuracy. We found that there is high sensitivity, specificity, and area under the curve. And we also conducted a patient satisfaction survey, which revealed that 73% of the patients were satisfied with automated screening, 13% were neutral about it, and 86% said that the screening system was easy to use, and patients recognized the benefits of the system, as 77% agreed they would reuse the system, and 78% would recommend the screening to friends and family. And 43% of the patients said they would prefer not to pay out of pocket for this, and of those were willing to pay, a quarter of them said they will pay $11 to $50. And we also interviewed the care providers. 21 of them were interviewed, and 76% were satisfied. And the providers found that system was very convenient to use, and they also felt that the presence adds value to their eye care practice. So in summary, this is an effective and feasible system in non-eye care settings in Australia. And with the high diagnostic accuracy, the system enables early detection of referable DR. And positive feedback from both patients and care providers supports its integration into routine practice, and this highlights strong potential for broader implementation of this system to prevent vision loss due to DR in a large scale. Thank you.
Thank you so much, Dr. Joseph. Very nice work. The next talk is also on diabetic retinopathy. The topic is universal optimization of AI-based diabetic retinopathy diagnosis through cross-camera image enhancement. Over to you.
Thank you. So this was also part of the main project that we did. So this is to enhance AI-based diabetic retinopathy diagnosis through universal cross-camera image adaptation. And as we know, AI has emerged as a promising tool for early detection of DR. And most existing AI algorithms are trained on retinal images from specific populations and camera systems. This kind of limits their generalizability and performance across different settings. So variability in image quality across fundus cameras poses a key challenge to universal application of AI models. And addressing inter-camera variability is essential to ensure broad applicability of AI-based DR detection. So we aim to evaluate the effectiveness of a deep learning-based style adaptation strategy in improving the diagnostic accuracy and cross-camera generalizability of AI for DR detection. And the study setting was a high volume tertiary eye hospital in India. And we recruited prospectively 367 patients and 734 pairs of images captured using two fundus cameras. We used Optane resolved camera, which captured macula-centered images with a 50-degree field of view, and established top-count camera, NW400, which provides a 45-degree field of view. The top-count camera is static and manually operated. And images were human graded using the ICDR guidelines, and we measured the overall accuracy, consistency, and preservation of the image quality. So a deep learning based image enhancement model, SCR-net, was used to align the style of the portable camera images to those of the top-count images. So SCR-net refers to style consistent retinal image transformation network. So basically what it does is the model extracted the high frequency components from the source image and then reconstructed the target image from the high frequency component. So we evaluated 3 training scenarios using various combinations of original and transformed images to assess the impact of style adaptation. In scenario 1, the deep learning model was trained on the original training set and tested on the original test set. This served as the baseline, and in the scenario 2, style adaptation was applied to the training set, and the model trained on this adapted data set was evaluated on the original test set. This was to analyze the influence of training data alignment alone. And in the third scenario, both training and test sets were aligned using the style adaptation algorithm, with the model trained on the adapted training set evaluated on the adapted training set. This was to analyze the cumulative effect of aligning both data sets to address style variation. And these are examples of the style adapted images. The top row are the source images and the bottom row are the adapted images. And so this PSNR, SSIM are commonly used measures to look at the image quality and similarity. So PSNR, higher the value, the distortion of the image is minimum. And SSIM looks at the similarity of the original image and the adapted image, and SSIM of 1 is a perfect alignment, and we had very high similarity. So this basically, it shows consistent styles across different imaging systems while retaining essential anatomical and pathological details. And it confirms minimal information lost during the transformation process. And this is a busy confusion matrix, which basically tells that there is high accuracy in the top count images in identifying non-DR cases with stable sensitivity and specificity for advanced stages of DR. And for obtained images, the scenario 3 achieved the best performance. On scenario 1, there was high false positives for no DR cases, misclassified as moderate DR. In scenario 2 was even worse with because the comparison likely due to the limited diversity of image styles in the training data set. And scenario 3 effectively reduced the false positives significantly, improving specificity without compromising sensitivity for advanced DR stages. And we also looked at the overall performance, and in scenario 3, the obtained images had high accuracy and consistency. So this concludes that style adaptation using SCR-net enhances the generalizability of AI-based DR detection system. This enables seamless integration of portable fundus cameras into AI-based screening system programs without compromising accuracy. This facilitates scalable deployment of AI-based DR screening in underserved areas. Such innovations are vital for scaling AI adaptation DR screening and advancing global efforts to prevent vision loss from DR. Thank you.
Thank you, Dr. Joseph. So next we'll have Dr. Yuxiang George Kong, who will be speaking on validation of an online perimetry software, Melbourne Rapid Fields, compared to Humphrey Visual Field Analyzer's CETA Faster for glaucoma. Yep.
Thank you for the opportunity to present in this forum. It's another research from Melbourne, Australia. This research has recently been published early this year, and it's looking at an artificial intelligence enabled online-based visual field testing compared to Humphrey Field Analyzer. As you know, the problem with glaucoma is that glaucoma is increasing very so rapidly due to aging population, and that puts a lot of demand on the regular monitoring of patients. The standard type of perimetry has its limitations, such as large footprint and can be costly to purchase and maintain. So we have developed an online-based visual field testing system that can be used on any type of digital device. It has a full set of testing algorithm, including 24.2, 10-2, and 30-2, and it's registered with TGA and CE marking, it uses a particular machine learning algorithm to ensure the patient has an optimal testing condition during the test, and uses the camera to monitor for the gaze of the throughout the test. In this study, we compared the MRF 24.2 test against the Humphrey CETA faster algorithm. It is a cross-sectional study in 2 locations, one in metropolitan area and one in a rural area. 232 patients were involved, and the testing condition is similar to the Humphrey, where it was tested in a dim environment with near vision correction. This is an example of an output that, from the Melbourne Rapid fields. You can see that it is you can quickly interpret this result with a similar grade scale, reliability indices, mean deviation patterns, standard deviation values, and importantly, a reliability in terms of the gaze stability. Most of the patients were 60% of the patients were normal, and were glaucomatous, and there were 18% normal patients in this cohort. And the range of age was between 21 to 92 years old. The correlation between the mean deviation value from the 2 devices was very good, 0.87, with the blind element analysis showing the variability primarily is in the area of the moderate glaucoma patients. Similarly, with the pattern standard deviation, the concordance is also reasonably good with 0.73. In terms of testing time, the MRF testing time is about 1 minute longer than the CETA's faster, average 4 minutes compared to 3 minutes. But false positive rate and fixation loss was not statistically significant. Point-wise analysis shows that there's some slight differences in the threshold values for both central location and the very peripheral locations. And the overall diagnostic value of the 2 devices in detecting glaucoma, the manifest glaucoma, was similar. The AUC values for MRF and HFA was not statistically significant for both overall glaucoma and for early glaucomatous change. Some of the limitations of this study was it was a single cross-sectional study. There were 2 digital screens used in this study. There were no difference between the 2 screens, but in future studies we will look at even more different, more digital screens, and look at whether differences in screens makes a difference. We don't think it would, and we will also examine the patient experience. Just as a side, that our MRF test was recently being used in India setting, with Dr. Shibodo Patia performed a study in 370 patients, and 97% agree that it is that it is very simple to use in the Hindi-speaking patients. So we think that our device will be a very useful solution to enhance the accessibility of visual field testing in situations where there is limited access. And in our future research, we have developed a 24-to-Rapid protocol, and it has comparable testing speed to the Cetaphasta. Thank you.
Thank you so much. We'll move on to our next speaker, Dr. Florentina Priscilla. And the topic is Accuracy of Mobile Application-Based Visual Acuity Screening in School-Age Children, a Meta-Analysis.
Good morning. Thank you for the opportunity to be the part of APAO 2025. I am Florentina Priscilla from Indonesia. This is our study about accuracy of mobile application-based visual acuity screening in school-age children, a meta-analysis. I have no conflict of interest. This is our vision impairment and blindness is a major global public health issue that can be preventable or treatable for approximately 90% of people. And we can see here that in the low and middle income countries that there are many of the children come with the vision impairment. And in Indonesia itself, there are 71% from 350 children with refractive error become amblyopia. And in 2030, we can see that 175.2 million people expected to be amblyopia. And we can see here that when the vision impair occurs since childhood, it has more negative consequences, such as permanent vision loss that will decrease the social, education, and also the quality of life. So we can see that the importance of preventive measures and also the early intervention is important. And however, there is the limitation, especially in the low and middle income countries, there is the scarcity of the ophthalmic professional, equipment, and also the cost. So mobile application-based visual acuity screening for school-age children is ongoing development. So our study aimed to elucidate the accuracy of application-based visual acuity screening tool for the special population of school-age children. So these are our PICOs. And these are our literature searching that finally we got 6 studies, and we have already registered our study as Prospero database. These are our study. We had 6 studies involving 2,891 children. Most of the study design are cross-sectionals, and this study use various methods, but specifically there are peak equity, which are commonly used mobile application based. And our study come from the pandemic of COVID-19, that the global COVID-19 reduction the amount of time children to spend outdoor and their engagement in prolonged near works. It is significantly increased the incidence of the vision impairment. So we think how to halt the progression of the uncorrected refractive error to permanent vision loss. This is our social program that use the conventional of the charts for the visual acuity. There is the limitation for mobility and also the examiner comprehensions. So this is the schematic example of the integrated software to have comprehensive school eye health program. The trained teacher screen every student, and the data automatically create a referral of the children who have failed the screening. So they will more to the specialist care with the data that send automatically to the healthcare. So does the mobile application base provide accurate data for the school-age children? We can see here that when we did the study, the area under the curve was 88.7%, that indicating a good test quality, and also the sensitivity and also the specificity itself has a good also. It is specificity 89%, and also the sensitivity 77%. And also we can see here that when we did the random effect model involving the 5 studies, we use the logMAR difference, and we can see here that it is the homogeneity was good, and also there is indicating that a symmetric funnel plot indicating that it is the homogeneous study. So this suggests that the categorized as a good quality for diagnostic test, that no statistical or clinical difference compared to the standard visual acuity test. So does the examination of mobile application based by non-professional have a good results? From our study, it is said that homogeneous sensitivity and specificity result between studies in average of 80%. It is because of the strong connections between the examiner and also the children. And how do we boost the good condition? We can did the training for boosting the performance of the non-professional. So from our study, we conclude that the mobile application-based visual acuity screening for the special population of school-age children are accurate and also effective tool for the early detection and prevent the permanent vision loss. And we recommend to activate the school-based eye program, maximizing school-age children vision screening, while we train the non-professional examiner, and we also can have a low-end policy for this program. These are our visual acuity program in the underdeveloped region of Lampin, Nusa Tenggara Barat in Indonesia, and we still do the conventional one. So we hope that the following program can be held more coordinated with the mobile application-based visual acuity screening. Thank you for your attention.
Thank you very much. So our next speaker is Dr. Yuanjun Shang, and the topic is Time Series Quantitative Automated Assessment for Age-Related Cataract. Do we have Dr. Shang?
Dear guests and colleagues.
Okay, so we'll have a recorded video played. Thank you.
Good morning, dear guests. Good morning. Good morning, dear guests and colleagues. I'm Shang Yuanjun from Zhongshan Ophthalmic Center. Today, I'm honored to present my work, Time Series Quantitative Automated Assessment for Age-Related Cataract. There is no conflict of interest in this presentation. Age-related cataract, a leading cause of blindness in the elderly, poses significant clinical challenges due to its slow progression. While slit lamp imaging is the golden standard for evaluation, subtle change in early and progressive cataracts are often imperceptible to human eye. Traditional systems like log3, despite their widespread use, are limited by subjectivity, poor reproducibility, and low precision, creating a critical gap in objective monitoring and therapeutic follow-up. This gap becomes particularly evident in multicenter clinical trials for early cataract therapies, where inconstant grading across centers undermines the reliable outcomes. An objective automated solution is urgently needed. Recent advance in artificial intelligence offers promising solutions. Models like DeepLensNet achieved promising results using more than 6,000 single time point images. However, these models ignore two key factors: multi-angle spatial coherence and longitudinal progression. To overcome these limitations, our team developed a spatial temporal fusion model that integrates both spatial and temporal dimensions. This approach begins by aggregating features from multi-angle slit lamp images to capture a holistic view of lens opacity, then incorporates sequential data and memory mechanism to model disease progression over time. Our dataset, derived from a multicenter trial of early age-related cataracts, includes over 6,700 time series images from 500 patients. Each patient underwent 9 follow-ups over 104 weeks, with 4 log3 standardized images per visit. ensuring consistency in baseline cataract characteristic and cataract profile between training and validation sites. In spatial validation, our spatial fusion model demonstrated superior performance in cortical, nuclear, and posterior subcapsular grading compared to single image models, achieving lower MSE across both cross-validation and external validation. When examining temporal integration with a sequence length of 3, models incorporating 6, 12, or 24-month follow-ups significantly improved the accuracy in cortical posterior subcapsular grading over single visit assessment. Over 2 years, increasing sequence length further improved the accuracy. According to the MSE of external validation, the spatial temporal fusion model was better than the single visit model and better than the traditional single image models. And the optimal results observed at 24 months follow-up and sequence length of 3. Notably, in human and AI comparison, our spatial temporal model consistently outperformed ophthalmologists in grading precision. In conclusion, we developed an automated time series quantitative system for age-related cataract, integrating spatial coherence and temporal progression. It achieves granular grading with accuracy exceeding both traditional models and clinicians. This innovation holds promise for standardized multi-center trials and guiding personalized therapies. Thank you for your attention.
Thank you so much. Our next speaker is Dr. Harvey, and the topic is comparison of image review parameters from 2 different optical coherence tomography analytical workflows.
Good morning. I'd like to thank the organizers for the opportunity to present this. We do receive research grants from Zeiss. The most valuable resource of an eye clinic is likely the time of the doctor. And these days in a retina practice, we spend a considerable amount of time looking at OCT images and injecting medicines into the eye. We started out using print images, and these images were very useful because they gave us an idea of the disease activity, response to treatment. There are biomarkers that tell us that predict how well the patients will do, and therefore, by incorporating this, we now enter the age of personalized medicine. Print images are not very efficient because it's time-consuming to review them, especially if there's a large number of temporal images to view. They're also hard for patients to understand, and they're prone to delays and errors. If your printer breaks down, then you'll have to wait until you repair the printer. And more recently, digital systems have allowed us to simultaneously view all of the images from the patient's first visit, visualize the patient's response, and even quantify how well patients respond to the treatment. So we wanted to compare digital and print analog workflows in the management of eyes being treated with intravitreal injections. We gathered 10 trained retina specialists, and we had them review image sets. Half of them reviewed print images first, followed by digital images, and the other ones, the digital followed by the print. And then, based on the last image of each image set, the doctors would have to make a decision whether to treat or not to treat. And we timed how long it took the doctor to review the image until the time they made a decision whether to treat or not to treat. So the print materials, these were 30 sets of OCT print images from eyes with requiring IVI medications, and they were chronologically arranged. The name of the medicine given was indicated on the page where the treatment was actually given. And on the last page, this was deliberately left blank, and the rater had to make a treatment decision. For the digital image, we use the Zeiss Retina Workplace software. And in this software, the reviewers looked at the same 30 image sets. And in this system, you can see on top the macular thickness map. In the middle here, you can see the B scans, and then on the bottom, there's a graph that shows the central retinal thickness, the average cube thickness, the injection date, and the type of medicine that was given. And on the last visit, the doctor would have to make a treatment decision. These were our key measures. So I found that there was a significantly shorter review time when doctors use the digital workflow to review the images versus the print format. And the reduction was quite significant. It was almost 50% reduction. So if you took a minute to review an image set using the print format, you took half a minute using the digital format. And if you have to look at 50 patients a day, this could add up in time savings. In terms of treatment decision agreement rate, interestingly, the agreement rate was only 71%. That means in 29%, a different decision was reached by the doctor who looked at the print image, and then later he looked at the same digital image set, but a different decision was made. The treatment decision confidence level, this was self-rated, was higher using the digital workflows. So this is an example. On the left, you can see the print image, and on the right, you can see the digital image of the same patient, but a different treatment decision was made. This is another patient where on the left, it took 103 seconds to review this rather extensive history patient. On the right, 82 seconds. So there was a significant decrease in time, but the same treatment decision was made. The raters overwhelmingly rated that the digital workflows were more easy to use. So imaging is now an essential part of retina practice, and in this part of the world, at least, there's still many practices that use print images. This study probably underestimates the time savings because we didn't factor in the time it took to print the images, collect the images, and submit the images to the doctor for review. So differences in treatment decisions might be related to the ability of the doctor to figure out what's the dosing regimen based on print images. But on the digital images, you can clearly see here on the upper screen, this is more of a fixed interval treatment dose. And on the bottom screen, a treat and expend treatment dose was being used. And this is very easy to see on the digital workflow, but not too easy on print workflows. So in summary, digital workflows are more time efficient than analog or print workflows for reviewing OCT images. Digital workflows raise physician and patient confidence. They definitely enhance physician productivity and satisfaction, but whether a system is good for your practice will depend on a cost-benefit analysis. Thank you very much for your attention. These are my co-investigators, two of which are here, and we invite you to Manila in December for the AP-VRS. Thank you.
Thank you, Dr. Hui. Next speaker.
Our next speaker is Dr. Kendrick Shi, the co-chair, and his topic is Deep Learning, Automated Diagnosis and Grading of Cataracts using Color Fundus Images, and it's called the Fundus Cataract AI Project. Over to you.
Thank you to my co-chair. So I'll be sharing about using fundus images to screen for cataracts using AI. So there's been a lot of work on cataract diagnosis and also screening using slit lamp technology. We wanted to propose something using fundus images. So this was sponsored by our health bureau in Hong Kong, but none of us have any financial interests related to this project, to declare. So worldwide incidence of cataracts is increasing, and in fact, it's actually burdening our public healthcare system because 90% of our patients in Hong Kong seek public care, but that's only taken up by 1/3 of our eye doctors in Hong Kong. And so we have a screening program, we have a triage program. It requires referral from a medical practitioner, but it's really designed to rule out patients with irreversible blindness. So it's patients who will have retinal detachment, have uveitis and ophthalmitis, but it's not very good at helping patients who have reversible blindness like cataracts. So if somebody presents with symptoms very related to cataracts, they tend to be given a routine appointment. And in Hong Kong, it can be 2 or 3 years. Post-COVID, it went up to 4 years before you're even seen by an eye doctor. So what we wanted to do was to use machine learning to be able to modify this and not need to use referral letters and be able to screen these patients in the primary care setting for cataract density. So if you look at a fundus image, it does give you more information than the back of the eye. So if you look at some of these images, some of them are not very useful to us normally to look at the fundus because it's very blurred, but that blurriness actually gives us information on the cataract density. So we hope that by training this algorithm, we'll be able to use it for cataract diagnosis and also stratification. So the first part was to actually train and validate the model. Second was to compare it to current practice. We used an automated DLS to screen for non-diabetic Chinese patients age 50 and more presenting with chronic blurring of vision for more than 3 months. The idea was to exclude anybody with potentially acute or sight-threatening causes of visual loss. So we used a efficient net and we created the training algorithm followed by validation. And so the data set that we used for this was a data set that we had from a screening program that we ran for 5 years. From that, we took about 16,937 fundus images, again, from patients who are age 50 and above, Chinese or ethnicity. And we eliminated some of them due to very poor image quality and those that had cataract surgery already. And we divided this into categories such as normal, early cataract, and visually significant cataract. So the way we classify it was normal, meaning no cataracts, early cataract, meaning there is a cataract, but the visual acuity is better than 20/40, and visually significant cataract are those with a cataract and vision less than 20/40. And the reason why we have this cutoff is because the listing criteria in the public sector in Hong Kong is less than 20/40 visual acuity. So we split it up into training, validation, and learning sets as well. So if we look at the outcome, so this is the internal validation results. In the end, we used 11,544 images, and we split them into normal, early, and visually significant cataracts. Looking at the sort of the different mappings, you can see that the ROC, the AUC, is actually quite good. So normal versus others, early cataracts versus others, and cataract versus the rest. So sorry, when we mean cataract, we mean clinically significant cataract. And you can see that differentiating normal with cataract is probably the best with the AUC of 0.95. When we compared it to an external validation data set, so this was an additional 600 patients that we saw at our Grantham Hospital Eye Clinic, the AUC dropped slightly in terms of external validation, but it still did perform quite well, especially with normal versus the rest. And in fact, what we see here is actually differentiating clinically significant cataracts from rest is actually much higher at 0.96. So this is a heat map. It tells us that when we're looking at these fundus photos, the AI is actually using the disc and the macula as a reference point. So if it can see it very clearly, it knows there's no cataracts or very early cataracts, and if it's very blurry, then it determines it as clinically significant cataracts. So the real world usage is that we looked at an additional 638 patients going through this algorithm, and what this algorithm will pick up is that we'll have actually about 36.2% patients who are routinely referred with clinically significant cataracts already. So this does increase the workload of our eye clinic, but the first thing is that we need to identify more patients with cataracts in order to be able to increase our cataract workflow. So it does have a positive impact in that you don't need a lot of information, can be more objective, but the limitations is really single condition focused, and it relies on a larger capacity for cataract surgery in the public sector. So in conclusion, it means that machine learning can be able to accurately diagnose and triage cataracts, and we can democratize this in terms of new case booking, cataract surgery listing, and we can make this available in other primary care systems worldwide. So with that, also want to invite you to APAO 2026 in Hong Kong next year. We'll be co-chairing this. And if you want to come again, I know most of the people here might be retina specialists, but we also are hosting ACS next year as well. So look forward to seeing you in Hong Kong. Thank you.
Thank you, Dr. Shi.
And the next speaker is my co-chair, Dr. Divya Rao. So she'll be speaking on advancing glaucoma screening, Medios AI's real-world validation across multiple ethnicities and device-agnostic capabilities. Thank you, Dr. Rao.
Thank you so much, all of you, for joining us today. And I'll be discussing a little bit about our experience of using a smartphone-based AI technology. Here are my disclosures. Some of the technology that I'll be discussing today is relevant for this talk. So glaucoma is the leading cause of global irreversible blindness, and the pooled glaucoma prevalence ranges anywhere between 2.5 to 5%. And alarmingly, more than 90% of glaucoma is undetected in developing countries, with 50% being advanced and 20% being blind. And compounding this problem is really a lack of trained glaucoma specialists. And as we can see, there's really absence of global screening guidelines for glaucoma. However, a high-risk population screening strategy can benefit from a higher positive predictive value and potential cost effectiveness. And there are studies from developing countries showing that glaucoma screening can indeed be cost effective. However, there's no ideal single screening tool so far. So what's the real challenge with glaucoma screening? As we all know, the diagnosis is not simple, requires clinical examination, and also looking at both structural and functional tests. And if you see here, all the tests that we do in the clinic and look at how they perform in terms of sensitivity and specificity, this meta-analysis showed that something like a tonometry has very low sensitivity but a high specificity, and something like RNFL thickness on the OCT has about 79% sensitivity and 92% specificity. So ideally, you really want the tool to be up there in the top left corner to have the right balance between a sensitive and specific tool. So can AI serve as a glaucoma screening solution that's adaptable to diverse populations? So we developed and validated a technology on a smartphone-based fundus camera, and this AI works completely offline, not requiring a cloud base, not requiring cloud inferencing, and with a click of a button generates a report for referable glaucoma in 10 seconds. It also has class activation maps or heat maps that point to probable areas of abnormality. So there are assistive neural networks that look at the quality of the image and also localizes and crops around the disk. But essentially, the engine is two main models. One that is a segmentation model that evaluates the cup and disk and gives a vertical cup to disk ratio. And the second one is a binary classification model that looks at optic nerve head and RNFL changes and gives a recommendation of refer or no refer. And this is sort of into three stages. Those with referable glaucoma, we call it urgent referral. Those with this suspect, a suggested referral, and those with no referable glaucoma, a yearly follow-up. So we looked at the performance of this algorithm for referable glaucoma first on a multi-ethnic and multi-device, and we did a multi-device evaluation, and the dataset source for this was the Rotterdam IPAX AIOS dataset, and which included data from 500 screening sites that represented various ethnicities from various camera systems. The second dataset was a pooled analysis from 3 clinical tertiary sites from a South Asian population coming from the portable fundus camera. So the first dataset had over 100,000 images and had adjudicated grading by graders who were trained and evaluated using the European Optic Disc Trial Assessment, and this required a rigorous trial period. And as you can see, there was wide coverage across different ethnicities. And the graders actually graded this into referable and no referable glaucoma. The second one came from 3 different centers, and here the imaging required the smartphone-based fundus camera, and it was a stage mid-Riasis. The grading protocol involved a glaucoma specialist here who gave a diagnosis after utilizing all of the investigations, both structure and function. And we call referable disease as anyone with established glaucoma and disc suspects, and compared the AI output, which was based on fundus images alone, to a glaucoma specialist who had all of the tests to make a final evaluation. So in the first one, that is the Rotterdam IPAX AIOS dataset, the sensitivity was 91% with a specificity of 92% and area under the curve of 0.95. And on the second dataset which was pooled from across the 3 tertiary centers, we pretty much had similar sensitivities and specificities for referable glaucoma. And this is just to show you a few cases from early to advanced glaucoma where the class activation maps were pretty accurate, pointing to areas of abnormality that was seen both on OCT and correlated with HVF as well. And the accuracy of the model increased when the severity of glaucoma increased from 87% to 96% from mild to advanced. So if we see all of the individual tests from the first graph that I showed, both of the evaluation shows that it was essentially in the top left box that I mentioned earlier, showing that it had the highest sensitivity and lowest false positive ratio among all other individual glaucoma tests currently available. We've actually deployed this in India now, and this AI-led screening has led to screen close to 500,000 patients now and has detected close to 10,000 cases of glaucoma. And just to give you a sense on how we have looked at the prevalence across India, we've seen a median prevalence to be 3% across most of the states that we've looked at. So in summary, this AI that was evaluated on monthly ethnic and device agnostic capabilities and has demonstrated a robust performance. And this was due to the diverse data sets that was used during model training, and it was able to generalize across different geographies and was tested against the standard of care diagnosis. This could be a useful tool to empower ophthalmologists with more information, especially when there's lack of sophisticated equipment like OCTs to make better clinical decisions. The offline capability is valuable in community settings when you can't rely on internet access or cloud-based infrastructure, enabling cost-effective and rapid screening. And real-world implementation data is promising to screen at-risk population. Thank you so much, and really thank my team as well as our collaborators, without whom this would have been possible.
Thank you, Dr. Rao. So our next speaker is Dr. Shangwen Kong, and the title is Optimizing Pathways for Large-Scale Refractive Screening in Children in Xinjiang. Do we have Dr. Kong here? Or do we have a recording from Dr.? Okay, so unfortunately we don't have Dr. Kong here, so we'll have to move on to the last talk.
Sure. The last speaker is Dr. Wee Zhu, and the topic is a machine learning model on orthokeratology lens fitting based on corneal topography data.
I think unfortunately Dr. Su is not here, and there's also no recording. So,
Okay.
so with that, unfortunately I think it's to do with a lot of visa issues. But so with that, I think we have all our talks, but that means we have a bit more time for discussion, and we're thankful for all our speakers to be here to continue this. So does anybody have any questions from the audience? Yeah, Dr. Shimizu.
Where should I talk? Yeah,
okay. You have a
I'll
good
ask
voice,
about
yeah.
the Francis photo, and I believe there is a multiple other. Thank you. So the question is that how did you detect other lesions? For example, corneal opacities, degenerations, not just cataract. Because in the fundus photo, many patients are referring to us, says that patient have a cataract with the fundus photo, it turns into be corneal opacity or degeneration on the stuff. So how do you evaluate that?
Thank you, Dr. Shimizu. Yeah, I think for our fundus photo evaluation, naturally the initial training, we removed all the patients with corneal opacities and also other fundus findings such as severe macular disease in order to fine-tune the machine. So yeah, I think the external applications may be quite limited because in the context of corneal opacities, I think it would have a very big difficulty differentiating.
Thank you. So if we can validate the corneal opacity and cataract in the fundus photo, that's an NEJM.
Yeah,
Right.
that would be
Yeah.
fantastic. Yeah, thank
Thank
you,
you.
Dr. Shimizu.
Just along those lines, I had another question for you, Dr. Shi. So I think you used the IDEN camera images.
Yes.
Okay. I was just wondering, what's your sense on generalizability of this model across other camera systems?
So
Have you looked at that?
Yeah, we actually trained the model with several systems.
Okay.
So including the ADON. The ADON one gives the clearest differentiation because it's a confocal type of camera. It differentiates a lot of or exaggerates a lot of pathology. But we've been using an OptiView fundus camera, one of the old generations that we have in the across some of the general outpatient clinics as well. The external validation model still holds, but I think that's where you get the 80-something% drop instead of the 90-something% AUC.
Okay. So it could possibly be used across portable camera systems as well.
That might be difficult because I think the current ones that we use are the ones that are large cameras that can really be based in a clinic rather than those that are portable.
Got it.
Oh yeah, that would be.
Yeah, actually, we did look at one such model, which was trained primarily on desktop systems and saw how that could generalize on portable systems, but it did require more amount of fine tuning. So I was just wondering if you had any experience on that. Yeah.
I've got a.
Sorry, I was going to ask you, you said that the area of interest was the disc and the macula.
Yep.
Do you know what exactly, or at least a hypothesis of what the AI system is analyzing? Is it just the clarity of the image, or do you have any hypothesis there as to what the AI system is looking at to decide whether the patient has a cataract or not?
Yeah, thank you, Dr. Bamwani. I think the clarity is the main thing that we're seeing as a difference in terms of the heat map. Yeah,
and again, related to that, if there was a corneal opacity or cataract, will both be picked up as a cataract by the fundus camera then?
Yes, that's what our findings are. Although we see very few corneal opacities in patients without prior eye assessment. Yes.
I've
Dr.
got a
Kong.
question for Dr. Shimizu. Yeah, I find your that the slit lamp attachment to the mobile phone to be amazing. Great work. How two questions. One is how automated is it at the moment? Do you can you sort of take a photo on the app and then it will automatically give you a grading at the moment, or does it have to it's currently more of a research and you have to sort of do additional analysis before you provide the grading? Secondly is, can it be used for other anterior segment pathology, such as angle closure assessment, etc.?
Okay, thank you. So right now, I have my model here. So you can use it anywhere.
Wow.
Because the model is in the cloud system, so that you can use it as long as that you're connected to the internet. So that's our limitation, because we want to send many models into our system, but that the application is gonna be super heavy, and the screen should use much more better phones that they cannot afford, too expensive. So our idea is they are connected to the internet, so that we want many models on cloud. When they connect to the cloud, they can use it. So the first answer to your first question is that you can use it here, right now, anywhere. So the second question is that yes. So right now we have a model for the cataract anterior chamber depth estimation, and yeah. So I heard great thing in this APL that there is a many patient with angle closure, not like in our country. So, but we already have a model to calculate the trabecular iris angle from anterior segment OCT. So I think we can just install that for the web application. We have a mobile model to estimate tear film breakup time, which is my specialty. I'm a dry eye specialist. We have a corneal opacity model, anemia estimation model, hyperemia. So I think that's gonna be pretty integrated into the our system shortly. So that will be an answer to the second question.
I just had a follow-up question for you. So I think it was primarily for nuclear cataracts, right?
Yeah.
So is it like a fixed slit?
Exactly.
Could you also do retroillumination going forward?
That was a great question. So the limitation of the device is that the angle and the slit beam is fixed.
Okay.
Yeah, because we use the light source of a smartphone, so it's gonna be a limitation for a device. So that's why it's great for the screening, but not for us.
Thank you.
I have a follow-up just with Dr. Shimizu while there's a mic, because you use a smartphone, and a lot of the smartphone, they have their own computer processing of images now. Do you find is there a big difference if you switch between smartphones?
And that's
Is
a
it
great
quality?
question. And there's a two-way of answer. Number one is that so far we only use the data of the iPhone, so the data set images are nearly equal. So there won't be any variation. I mean, I think the variation will be the light or external light. If it's dark, it's gonna be a little bit different. If it's bright, it will be. But the second way, we are making the model with the Android as well and collecting the data. So if we validate that iPhone model data into the Android, it might gonna be changed. We don't know. That's what we are trying to figure it out. And if the result is bad, we have to think about a different way.
Thank you, Dr. Shimizu. I had a question for Dr. Kong, Dr. George Kong, on the online software compared to Humphrey. At the moment, you're comparing it to CETA Faster, which is very good for screening, but have you found any differences in its performance for monitoring of disease progression for these patients?
Yes, we have previously done comparison with CETA standard. As well as CETA Fast. We've published that a couple of years ago. So we did a 6-month sort of progression assessment. We asked the patient to come back every 2 months to do a visual field test, and we looked at test-retest variability, and our test-retest variability was similar to CETA standard and a bit better than CETA Fast. But we wanted to sort of look at a comparison with CETA Faster in the most recent study. Yeah.
That's fantastic. So it means it's quite applicable across the board for monitoring.
Yeah. So we think that it is absolutely suitable for monitoring as well as for screening.
Thank you.
Thank you.
Just as a follow-up, does it require standardization, especially given that you can use this at home as well?
Yes.
How would you ensure standardization of the illumination, the digital device that you use, the screen, and all of the settings required?
Yeah, so to standardize the test for different screen sizes, it uses a calibration step where you adjust a virtual ruler on the screen against something that's a physical object of a known size, so like a credit card or something like that. But for the screen brightness, we find that the small differences in the maximum screen brightness with different digital devices makes very little difference in terms of the contrast assessment. So we think that it should be good. And for ongoing monitoring, if especially if the patient uses the same machine at home all the time to perform the test, then in terms of monitoring, it would be suitable to detect any changes.
Great, thank you so much.
So I have a question Dr. Bhamwani first.
Yeah, sorry, I had a question for Dr. Joseph for the study from Australia. So you had presented that it's very similar to the project that we had in Canada, and you had presented some data on sensitivity and specificity. So what I noticed was that the sensitivity was about 80%, but the specificity was about 95%, which is sort of opposite to what we would expect from a screening test. So why was that the case? And also, is there any medico-legal or liability issues with missing diagnosis of diabetic retinopathy, and who takes that responsibility? Because that was one of the concerns we had in Canada, and what we were told by the company that we went with was that the company actually takes medico-legal responsibility if there was a missed diagnosis of diabetic retinopathy on that software. So I wanted to ask you what your experience was on that.
Thank you for asking. So that's true. In this particular study, the sensitivity is slightly low, but this was the field testing, the first field testing we did. in non-eye care settings, but there has been many other validation studies which all has sensitivity more than 95. Yeah, so and this also, I think one of the centers was an Aboriginal clinic, and there was a lot of acceptance issue, and we also used differential inclusion criteria because it was conducted in the form of a pragmatic trial. And in the initial centers, we recruited everybody above 50 and people above 18 when they are diagnosed with diabetes. And in the last clinic, we wanted to look at if there is a difference in people with severe and suboptimally controlled diabetes. So we recruited only people with diabetes. So there was a lot of variation in the this thing, and we also used two modalities basically. Because it was like a field testing. In the first one was a kiosk-based system, and the second one was a portable camera. And we were learning in the process. So initially, we excluded people when there was when there was difficulty in taking a image, and then in the second and third onwards, we started including everybody, just to see how the system works on that. So it was a pragmatic trial, and I agree that that's not ideal.
Dr. Joseph, I just had a follow-up question to that. What really struck me was your mean age was actually 60 plus, and your gradability was pretty high. You just had ungradable images of 13%. So was it like a staged mydriasis protocol that you use, or were they all dilated patients? What was your protocol in terms of imaging?
Yeah, it was completely non-mydriatic. There was no mydriasis involved.
Okay.
And only thing is we did repeated imaging.
Okay.
And because it was in a clinical setting, we were able to, and we had support from the GPs, and it was their patients, so they recommended. So the patients were cooperative to do more than one. So we tried like up to 3 times most cases. I think that's contributed to the credibility.
And the other question I had was this a cloud-based AI as well, or was this completely offline on the edge?
In the study, it was a cloud-based, what we did in Australia, but it can be localized as well.
It can be
localized. In a couple of studies we did in India, it was localized to the system. Yeah. Thank you.
Nice. Go ahead. I'll go next.
I have a question for Dr. Bambwani about the protocol. So you mentioned that there's actually quite a surprising number of diabetic patients who were never seen by an eye doctor. But from my understanding, in Ontario, a lot of the primary screening is done by optometrists. And you showed that actually a lot of patients accept this AI screening. But inspired by some of the work that Dr. Joseph was showing, how many of them would be willing to pay for that treatment and or that assessment, and would they value it just like an optometrist visit or a
so the thing with optometrist visits in Ontario is that they are actually allowed, like people over 65 are allowed one visit every 2 years without having to pay for it. But again, there are barriers, like for some optometrists, they like to do fundus images and OCTs when patients go in, and those are not covered. So that's sort of like a barrier to access care. And again, the wait lists being a very, it's a publicly funded system, so the wait lists are very long. So sometimes to get into an optometrist's office takes about 6 to 8 months, similar to how it is in Hong Kong. Seeing an ophthalmologist sometimes takes 1.5 years to 2 years. So if they are already being seen by a primary care provider, if this is done at that setting, then the barrier to access is obviously lower. And it also reduces the workload of eye care specialists, because instead of having to see 100 patients, you're having to see 20 patients for an exam. And with respect to paying for it, again, this study was funded by a grant, but there is no, there's no Canada-wide code that is available to bill for an AI exam. Like different provinces have their own healthcare systems, but on an average, if we compare it to the US, the amount that practitioners are funded for such an exam is close to about $50 US. So I think it would probably be in that range if it was to be approved in Canada throughout the country.
Thank you.
I I just had a couple of follow-up questions as well. So your table was interesting where the sensitivity was always high, but the specificity kept ranging quite a bit. I might have missed this, but what was it like in this study?
So the project we've done like many phases of this project. The one that I showed now was actually just on it didn't calculate sensitivity and specificity. It was mainly the feasibility and the patient experience. But there have been a number of studies on this IART system.
That's right.
And most of them show sensitivity over 95%.
Right.
Specificity changes, but that's also because it is the camera is different in different studies. So depending on how good the images are, that sort of decides what your final positive and negative predictive values are. So the camera that we used, I tried a number of cameras, and as you must have seen from your experience as well, a handheld camera, even though it's convenient, is sometimes not as good with respect to image quality compared to a tabletop camera. And the one that we used, we found like the technicians were so, like it was so easy to use that after taking 2 or 3 images, they were sort of adept at doing it. And that's also the reason why our we had about 93% or something we could do without mydriasis, without anything. We could capture images very easily. If we use mydriasis, it was about 94 or 95%. So there were very few that we could not screen. And especially when we were introducing a new technology, which everybody may not accept very easily. We wanted that to be the case so that we don't miss anybody who's actually made the effort to come into participating into the study.
That's right. Have any of your studies also looked at what is the referral rate once you actually detect them?
So this study actually looked at that.
Okay.
So we had about 77% of patients followed up. So out of the 202, we had 42 that needed to see an ophthalmologist, and about 36 of them ended up seeing an ophthalmologist. But again, this is a single center study, and the way it was set up was that the primary care office and the ophthalmologist office were actually pretty close to each other. So again, it reduced barriers to referral and barriers to entry into the healthcare system. But we have to see whether the same applies. So the second phase of our project is to actually go to smaller centers where there is no ophthalmologist or optometrist, and then into the remote communities as well. So we'd have to see how much the referral rate is when we go to the smaller centers.
Right. Yeah, because you got pretty high referral rates, and we found that to be challenging. At the end of the day, you would want everyone to be moved into the referral care pathway so that they actually get the treatment. And it's great that you're looking into that. And if you figure out a way in those remote areas how they can actually access care, I think it'll be great.
Thank you.
So I have a question for Dr. Uy. I think it's fantastic. The Carl's Eye suite is fantastic, but oftentimes these suites, they charge per user to be able to access the system. Have you looked into whether it would be quite cost effective to be able to set up, access by digital access hospital-wide in this?
Yes. So in the system we use, the software comes with the equipment purchase. So there's no, pay-per use.
Oh, okay.
Yeah, but of course there's a significant cost to purchasing the software. So you have to analyze your throughput, how many patients you see, and then figure out whether the added cost of getting the software will will be justified by, your time savings. But pretty much if you're in a busy practice, it's worth the time. It's not just the doctor's time, but the technician's time, the fundus photographer's time. All of these are savings that you have to pay for. They're just not usually factored in.
Thank you. I have a question for Dr. Patera, because I think and like TB is also endemic in Hong Kong. We get quite a few of these TB uveitis, but what we see in these TB patients is you get other types of vasculitis and retinitis, such as CMV retinitis in immunocompromised patients. Does your system, are they able to sort out these types of uveitis, so non-TB related uveitis from TB?
Yeah, so far we just look at these groups because it's really preliminary stage. And actually the code that is built up based on Rotterdam cohort, which doesn't include uveitis and also UK biobanks, thousands of images without uveitis. But then the idea is how to start with uveitis. And I think there's, as I mentioned in the presentation, that it will be difficult if we cover all of these 30 different entities, all of these infections. So we start little extra step first with this kind of uveitis. So I think the next step should be first to look at the largest data sets that include multiple source of imaging modalities that you already discussed in this discussion, that probably different tools will have different image and how the software works to adjust based on these differences. How's the different ethnicity probably with the vascular networks will be different. So after that, and then inter-observer reliability, I mean the operator, and then after that, then go beyond these two different entities. Why we select toxo? Because toxo and TB are the two common infectious uveitis. We can also add CMV later on, herpetic. So yeah, I think still there's a step ladder onwards. But yeah, I agree with you. It should be feasible. But right now, we don't look at the specific features like hemorrhages and other stuff, retinal infiltrates like that. But of course, that's in the plan next step to also analyze these adjacent structures as well.
Thank you, Dr. Purata.
Thank you.
Just wanted to ask one more question to Dr. Priscilla about the
Last question.
very last. You showed that these app-based visual acuity assessments are quite effective, but going into very rural areas, do you think actually just going back traditional-based, using paper-based visual acuity assessments would be more cost-effective because you're not paying for power to charge your phones, you don't have to have devices, you just use cards and distance in that case?
Okay, thank you. Thank you before, Doctor. It is actually because my social activity first in Nusa Tenggara Barat. When we go there, it is like for the classroom, is it not too long? So we have difficulty to find the classroom with 6 meter for this Snellen chart or conventional chart. When we did the interview to the teachers, mostly even it is in the underdeveloped area, they still have the mobile phone for their private use. And when I asked them to like download the visual acuity chart, it is like they can use it, and it is more easier for her and for them to did the screening besides the Snellen chart or the visual acuity conventional chart.
Oh, thank you.
Thank you.
I had a follow-up question, but we'll take it later. I think we're running out of time.
Yeah.
But thank you all so much. This was
Thank
a
you.
very engaging session, and we really enjoyed all of the talks, and
Yeah.
hoping to meet you all again soon.
And thank you for the Q&A as well. My pleasure to do this.
Thank you so much.
Yeah.